Hello, everyone. Thank you so much for joining us today, and welcome to this webinar, Value of Lifestyle Management Programs for Improving the Health and Well-Being of Older Americans During COVID-19 and Beyond. My name is Jordan Furmeister. I'm an Associate Project Director at the Society for Public Health Education, or SOPHIE. And on behalf of SOPHIE, we're pleased with the interest in today's webinar and thankful that you have taken the time out of your day to participate. Before I hand it over to our speakers today, I would like to cover some housekeeping items. First, please know that all attendees are muted for the duration of today's webinar, so you're placed on mute currently. To interact with our speakers today, please use the chat box. You should be able to see this chat box function around the bottom of your screen. After hearing from our presenters, we will have a question and answer session with the time remaining. So get those questions ready for the end. Questions can be submitted at any time during the webinar by typing in the chat box. We value your feedback and ask you to complete the feedback form that will be found in the webinar drop-down menu immediately following today's webinar. Your evaluations of this program will assist us in planning future webinars. Please know that today's webinar is being recorded and will be available and archived on SOPHIE's LMS, which is the Center for Online Resources and Education, or CORE, within 24 hours. For those watching, you will receive an email from SOPHIE to access this recording. An application has been approved for 1.5 entry-level Category 1 Continuing Education Contact Hours, or CECH. This program is designated for Certified Health Education Specialists and Master Certified Health Education Specialists, which are CHES and MCHES, to receive a total of 1.5 CECH. For those who choose to apply for continuing education credit, please visit SOPHIE's eLearn at CORE and sign in with your my.sophie.org account. CE fees do apply. As a quick introduction, SOPHIE is a nonprofit organization founded in 1950, dedicated to providing global leadership to the profession of health education and health promotion, and to promote the health of all people. Members include health education professionals and students throughout the United States and internationally. The organization promotes healthy behaviors, healthy communities, and healthy environments through its membership, its network of local chapters, and its numerous partnerships with other organizations. Plan to join us for the SOPHIE 2021 Digital Experience Annual Conference this April 7th through May 11th, 2021. Check out our mobile app for our conference schedule and program. Registration is now open with advanced registration rates. We encourage you to visit the SOPHIE website for additional information. Now I'm excited to introduce the three speakers that you will hear from today. The first speaker will be Dr. Kate Lorig. Kate served as the director of the Stanford Patient Education Research Center and was a professor of medicine in the Stanford School of Medicine. Kate is currently a partner of the SelfManagement Resource Center. She has authored several books and many articles about arthritis, chronic disease in general, health education, and behavioral science. The second speaker is Paul Hepfer. In his role as CEO, Paul has been instrumental in continuing to leverage and expand Project Open Hands relationships with government partners, health plans and providers, private funders, donors, and volunteers. As an advocate for medically tailored nutrition interventions, he furthers the mission of educating healthcare payers and providers on the role of medical nutrition in health outcomes. The third speaker is Teresa Ambrose. Teresa is the manager of the Diabetes and Health Behavior Unit in the Health Promotion and Chronic Disease Prevention Division of the Minnesota Department of Health. In this role, she guides efforts to prevent and manage chronic conditions to improve the lives of all Minnesotans and reduce health disparities. Ms. Ambrose has over 3 decades of experience assessing community needs. Without further ado, I'll hand it over to Dr. Kate Lorig.
Dr. Lorig, you're on mute.
Thank you so much. I'm so pleased to be with you all today, and especially fellow SOPHIE members. I'd like to add a little bit to the introduction because I think it's really important, especially as you look at my slide, and that is that Paul is here as the chair of the Evidence-Based Leadership Collaborative. And this is a group which fosters use of evidence-based programs for older Americans. And we can talk more about that if you'd like. And my reason that I'm here today is that I happen to be the vice chair of the same collaborative. And it is the EBLC which is co-sponsoring this workshop. Now, having said that, let's talk a little bit about arthritis and why any of you should care. My guess is that some of you out there, and unfortunately I have no idea who you are really experts in arthritis, in which case the first few minutes are going to be a little bit boring. But a lot of you have never given much thought to arthritis. And I certainly hadn't when I was offered a job in the field many, many years ago. And I'll talk about that in just a minute. But let's go to the next slide. Just a little bit about arthritis. About 23% of all adults in the United States have arthritis. That's a lot of people. There's also more than 100 different kinds of arthritis. The most common of these is osteoarthritis, which almost all older people get, but there's lots and lots of other kinds as well. And I promise we will not have a lecture today on all 100 types of arthritis. Almost all of these limit people in their daily activities. About 1 in 4 people with arthritis have severe joint pain or persistent joint pain. And nearly a quarter of people with arthritis report no physical activity. Now, this ends up being really important no matter what field you work in health education. Because if you work with hypertension, one of the things that you want people to do is to move and exercise. This becomes exceedingly difficult if somebody has arthritis. If you work with diabetes, the same thing is true. If you work with older people and you want physical fitness, again, arthritis gets in the way. It gets in the way in another way too. One of the things that we know is that about 1/3 of people with arthritis are clinically depressed. Now, they don't know they're depressed. If you ask them if they're depressed, they'll probably tell you no. But if you give them a standard depression screener like the PHQ-8, they will come up with scores of 10 or above, which is a score of clinically depressed. This ends up being important for almost all of us in health education that are really interested in behavior change, because it's very, very hard for someone who is depressed to change behavior. And if we don't deal with the depression, we're probably not going to deal much with the behavior. Given the importance of this disease, why is it that health educators have, for the most part, pretty well ignored it? And the reasons are mainly because it doesn't kill people. You can't see it. Sometimes people don't even know they have it. It's considered a part of normal aging, whatever that means, and therefore people don't complain about it. Also, there's not terrific cures, especially for even treatments, especially for osteoarthritis. There are for some of the other types of arthritis. We have some pretty exciting different medications for them. But given all these facts, it's a pretty much ignored factor for many of us in health education. And I will tell you now for my story that this was certainly true with me. When I entered this field many years ago, I really had zero interest in arthritis. I came from the field of maternal and child health. I made it quite clear that I was only going to work in the field for 2 years because Stanford had offered to pay for my dissertation expenses and to pay me as well. Sounded like a pretty good deal if I would do an arthritis study for them, plus which I could use the study for my dissertation. And so I said, fine, I'm a practical person, I'll do that, but I'm leaving in 2 years. This is not what I want to be doing. And as you can see, many, many, many years later, and several books and a whole career later, I'm still working in arthritis. And I'll also tell you one other story. And that is that early in my career, one of the luminaries in our field, who will go unnamed, said to me, Kate, this arthritis stuff you're doing is kind of interesting, but please don't plan to make a career out of it. You'll never go anywhere. It just shows that luminaries can be wrong. So that's my little background on arthritis. And for those of you that I'm bored, I'm sorry. And hopefully a few of you have learned a little bit about these diseases that you didn't know before. So let's go on to the next slide, please. So what is an evidence-based program? Because you're going to be hearing in this series a lot about evidence-based programs. This has a very, very specific meaning, and it means that these are programs that have been authorized by Congress for CDC and the Administration for Community Living, which is where aging money comes from in our government, to pay for. And to be an evidence-based program, they must meet 4 criteria. I know there's only 3 here, but there's really 4. First, they have to be tested in a trial using experimental or quasi-experimental design. These can be, and these have to be fairly large, probably 100 people or more, and they have to be fairly long, at least 6 months or more. Now, not only have they have to be tested, but the results of those trials have to have been published in a peer-reviewed journal. There has to be full translation to a community site other than the study site. So if it was studied in Palo Alto, the issue is, will it also work in Detroit or in Colorado Springs? And finally, it has to already have all the things that are necessary to make dissemination possible. And these include such things as training manuals, leader manuals, fidelity manuals, because intellectual property is involved very often, and there's licensing and legal issues involved. So all of these things have to be in place before you can have an evidence-based program. Once you have, excuse me, once you have these in place, then you can apply. There is a application form and there is a vetting process. And then if you are vetted and deemed an evidence-based program, you will be part of being eligible for funding from these funding sources. And more around the country, other funding sources are also using the same vetting process. So that's what an evidence-based program is. And we'll be talking mostly about evidence-based programs for older Americans. And the next slide, please. The CDC evidence-based lifestyle programs, and that's what we're specifically talking about today. These are the programs that CDC has deemed, has recognized as evidence-based programs and will pay for with CDC funding. I'm going to just say a little bit about these different programs, not a great deal. There are a group of physical exercise programs, physical activity programs, and these programs differ in different ways. The Arthritis Foundation Aquatic Exercise Program obviously is in the water. Walk with Ease, which is another Arthritis Foundation program primarily, is a program which is self-administered and it's individually done, or at least usually individually done. And it's a very nice walking program. Enhanced Fitness is a group exercise program that's available both in person and via the internet or via something like Zoom. And Fit and Strong is another group exercise program, which is specifically for lower extremity arthritis. While its whole body, it focuses on lower extremity arthritis, and it will soon be available via Zoom. It is available in small groups. So those are the exercise programs. And now if we can see the next slide. There are also some self-management education programs, which I happen to know a little bit more about because they're programs which we put together. There is the chronic disease self-management program, which is in both English and Spanish. And why would you do a chronic disease program as opposed to an arthritis specific program? Well, for the same reason that you'd do an exercise program across diseases. And that is that most older people that have one disease have multiple diseases. And what works in the field of behavior change for one disease pretty well works across the board for other diseases. And then we also have, because pain is the biggest presenting symptom or the biggest problem that people tell us about with arthritis, we also have a chronic pain self-management program, which is also available in English and Spanish. And these programs are available in multiple different modes that they can be given in. Can we see the next slide, please? So how can they be given? Different programs, different ways. All of them can be done in person. A few of them can be done just by phone. Some can be done by Zoom or another virtual platform. Some can be done by old-fashioned snail mail. And especially the phone and the snail mail end up being important. And they end up being important because while Zoom is absolutely wonderful, you all are showing this today, there are a huge number of people in this country that do not use the internet. And they don't use it for a number of reasons. One is that they don't have a computer, but strangely enough, that's the smallest reason. Two is that there is not availability of broadband, or broadband is too expensive. And the third reason is I just don't want to use a computer. And so you can give me one, but it doesn't make any difference. And so when we're trying to devise ways of reaching people, we need to devise many ways, very often with the same program. And so that's why the phone and the snail mail ends up being incredibly important in this whole suite of how we deliver programs. At the present time, these programs are reaching many people every year, and one or more programs are available in all the states. And if you want to know more about these programs, you'll find out more about them on the Evidence-Based Leadership Collaborative's website. You'll also find them under the Center for Healthy Aging on the National Council of Aging's website. And if you can't remember all of those, write me and I'll help you. All right, next slide, please. Paul, I guess we're turning this over to you now.
Thank you, Kate. Thanks for the introduction there, and I'm really glad to be with you all. I'm resetting my timer here. Great to be with you. I'm broadcasting live from the Project Open Hand Studios in San Francisco, California. It's a chilly day here, but I'm really happy to be with you all. So my topics are, I'm going to give you a little bit of background from a community organization perspective regarding implementation of evidence-based programs. And then I'm going to talk a little bit about the Evidence-Based Leadership Collaborative. As Kate mentioned, she's the vice chair for the next couple of years, and I'm the chair of the organization. So we work closely together on advancing the mission of the Evidence-Based Leadership Collaborative. So Raquel, next slide, please. Just for starters, just to give you a little context, I'm going to give you 2 minutes on the organization I work for now. I am the CEO of Project Open Hand in San Francisco. We have been serving San Francisco and the Bay Area for 35 years, providing medically tailored nutrition for people with complex chronic health issues. We started in the HIV world, but several years after that, we branched off into serving people with congestive heart failure, diabetes, end-stage renal disease, chronic kidney disease, cancer, and many of the health issues that that we talk about when we talk about lifestyle management programs. We do 1 million meals a year, and we have 9,000 volunteers a year that work with us. Next slide, please. We have a great story of our founder, which I won't get into today, and how we began as a humble nonprofit, but it's a great story that I'd love to talk to you about later on. But the reason I wanted to give you some context setting for the organization I've been with for the last 2 years is we do believe that our intervention is an evidence-informed approach to delivering medically tailored nutrition. Next slide. Most of our services, the majority of the clients we receive, we would classify the intervention at the top of this food is medicine pyramid, where it's more treatment than prevention. And it's really highly specialized because we have a team of registered dietitians that work with our chefs in creating the meal specific to someone's health condition, and also providing medical nutrition therapy for those clients. Now in COVID, it's via telephone, but prior to that, it's in person. But the reason that I didn't call this an evidence-based program is because we have not taken our intervention through the process that Kate mentioned earlier for us to receive the determination. And we have a lot of peer-reviewed research, but we really haven't taken the time to see if we're ready for that next step. We should be doing that, and under my leadership, we will be working on that, but we haven't gotten there yet. So next slide, please, Raquel. But what I'm going to focus on is now more my past 14 years working with the Health Trust in San Jose, California. And I want to summarize about 10 years of advancing evidence-based programs and scaling them into about 6 or 7 minutes. And I'm going to talk a little bit about my perspective as an executive for that nonprofit and why and the hows of advancing evidence-based lifestyle programs. Next slide, Raquel. So the Health Trust is a nonprofit. I asked the host of the meeting today where some of you all were from, and we saw a lot of .orgs and .govs and various suffixes on your email. So I assume you either work for a community-based organization or maybe a public health department or maybe a combination of both. The Health Trust is a nonprofit located in San Jose, California, about a $15 to $18 million a year nonprofit, 130 to 150 employees. And my responsibility there for 14 years as Senior Vice President of Programs was to oversee all the direct services that we provide within the organization. And I broke this down in kind of two ends of a spectrum for you all, because this is really how I saw some of our successes and challenges over the years. On one end, we had some highly specialized, and they still do, highly specialized services that were bound by very specific government funding. For instance, the Ryan White program, many of you might be familiar with, for people, low-income individuals living with HIV and AIDS. I think the Ryan White model of care is one of the best examples of a public health success in our nation. And I would love to see that model translated for people with diabetes, but it's a very, or heart disease. It is a very expensive model though, but highly, highly successful. And on a national level, people who are in the Ryan White program generally are experiencing better outcomes than people receiving private insurance with HIV. Very high viral suppression rates and retention into care. Very, very highly specialized. And the Health Trust provides the majority of those services for the whole county of 2 million people. We also provided a very restricted program in Medicaid enrollment. So that's a very, as many of you are familiar with, that's if you're funded to do that, there isn't a lot of wiggle room to provide other services to community members that come in seeking services from you. Those types of services are not very responsive to needs, developing needs of individuals. For instance, our folks that had HIV, many of them now have diabetes or heart disease. The funding was specific to services related to that health condition, really didn't allow us to provide diabetes education, believe it or not. Similarly with Medicaid enrollment, people would come and while they're getting enrolled, they'd say, well, can you give me some tools and tips on managing my diabetes? The funding didn't allow for that. So on the other end of the spectrum were many of the services we provided that I would call soft dollars, that were general fundraising dollars. These would be the Meals on Wheels program. Another example is a oral health education program where just some of our fundraising allowed us to teach family members about the importance of oral health. And again, those programs, although they were great ideas, many of them piloted successes, they really were difficult to scale because funding was volatile in those softer sides. Next slide, please. So really what I saw and what we saw as an organization, we saw a challenge in being able to fully meet the needs of our community members. And we wanted to be able to provide some of our clients receiving more specific care with services that weren't being met. And at the same time, in some of our community health, we wanted to be able to engage our promoters, our community health workers in other types of community health interventions, but we really weren't sure how to find material and curriculums that were backed by science that our funders would pay for, but that could also be delivered by our community health workers. And we actually, believe it or not, spent a bit of time trying to find an intervention that we thought our community health workers could be trained to deliver on a large scale. And it didn't have to look very hard because about 20 miles up the road from where we were headquartered, Dr. Lorig had a whole suite of these types of evidence-based programs. Next slide, please. So we had recognized the need that we really needed to better meet the needs of our diverse population. But we also knew that we really believed in the importance that we needed some outcomes we could report to our funders and that we could say that we are building and intervening towards. We wanted services that could be delivered by lay leaders, that we could utilize the community in the delivery of these services and not have to rely on nurses, LCSWs, MSWs, and a lot of other very competent, very highly qualified, and in some cases expensive health professionals. Then we also wanted an intervention that had the potential or already was eligible for reimbursement for some healthcare providers and partners like health insurance companies, community health clinics, public health departments, which would help maintain those services financially. And then we also were very keen on finding interventions that had the respect of the medical research service and quality sector. And through documented research, we wanted proof that these interventions would actually engage the community members and not be one-offs where people sign up and they never show up. I'm sure many of you deal with that on a regular basis. Next slide, please. So taking from the National Council on Aging's resources on evidence-based programs, I pulled some of these descriptions out that how they describe many of these programs. They make very efficient use of resources. They really help bring partnerships together, and I'm sure you'll hear some examples of that. They're much easier to replicate because they've been so well researched and they have so much efficacy behind them, and the training really helps with the replicability. And then also they really lend themselves to a variety of funding sources. They from a fundraiser like myself, which I am in much of my life, they help you tell a really good story that have health outcomes, but also they allow you to attract community public health departments and foundations because they have really great proven outcomes. Next slide, please. So the way we started at the Health Trust, now I'm thinking it must be 11 or 12 years ago, we wanted to start with the area where we were receiving the most requests from our community members. We literally had, we delivered thousands and thousands of oral health in-home presentations over 10 years. And after a period of time, we started hearing from the community, you know, we understand the importance of flossing and brushing, and we're really glad that you're delivering these, but you know, we have a lot of family members with diabetes. Can you provide us some education on diabetes and do a similar type? Instead of us coming to the clinic, can you bring it to our libraries, our churches, our homes? So we started, and we heard the same from our community health clinics, that diabetes was a very challenging issue in our communities. So we opted to start with the Stanford Diabetes Self-Management Program. Our community, our cadre of community health workers that were already trained in oral health and doing health insurance enrollment and some of these other efforts were trained by master trainers to be diabetes self-management program leaders. We trained people in Spanish, Vietnamese, and I believe we had a Tagalog group for a period of time, and Mandarin. And we produced material for health payers, and we also produced materials for the community to help us really promote those diabetes self-management programs. Next slide, please, Kel. So after a couple years of delivering pretty successful, and when I say successful, I mean we had well over 60 to 70% of people that started our 6-week diabetes program finished the diabetes program. We had our own evaluation team do some internal evaluation, and we found the results were consistent with the national data. So we felt really good about our approach to this. And one important factor too is that we had our diabetes lay leaders who stayed with us for quite a long period of time, and we were able to pay them, brought many of them on as part-time staff or paid them as a per diem stipend, you know, whatever worked best for them and the organization. So then we realized that we really wanted to build a portfolio to keep clients engaged in other aspects of improving their health. So a few years after our diabetes program, we first added the chronic disease self-management program. We then added fall prevention and a physical activity program that Kate talked about earlier. And after several years, we really worked at trying to navigate clients through the different programs. And when we, in many instances, if we had someone that wasn't interested in the chronic disease, we had something else to offer them, like a physical activity program that resonated with them in a way that a group diabetes class didn't. So some of the challenges I'd like to share with you, I think I'd be remiss if I didn't say that, that there weren't challenges along the way. One of those issues really involves the sustained focus by organizational leadership, people like myself and the CEO and the board of directors. You know, it's important to keep your executive team engaged and motivated about the successes that the community is realizing through these programs. And that's not always easy to do. And sometimes we take for granted, we think that, well, you know, we have the rates of diabetes are going up in the community, so we have to offer more and more workshops. But there's a tendency at the board level to say, well, when are you going to be done with this? Well, we're going to be done with this when diabetes rates go down, is what I would say. But that was a hard sell for me to make to the board members. And so you really have to approach it. We're in this for the long haul. We need to offer these programs indefinitely. Maybe you add more as you go, you know, you build your portfolio, but this isn't 6 months and we're done with doing this. And I think I've seen that in many communities where a community clinic will start these programs and they'll say, oh, we did that and, you know, we're done with that now. Well, you know what? You have a whole new clientele of patients coming in. You have a whole new set of challenges that they're dealing with. And so you have to be able to add to your portfolio of evidence-based programs to keep the community engaged and healthy. You know, one challenge we had a lot of requests for mental health, depression, social isolation programs, and we never quite figured out how to build that into our portfolio. And it's something that the organization is still working on. There are programs that address that, but we just we just weren't able to operationalize that in the time that I wish we could have. COVID-19, that enough said there, really. That created a whole new level of challenges for the organization because most of what we were offering were in-person group. As Kate mentioned, many of those evidence-based programs have been adapted to remote delivery now, which is really critical. And I think even after we find our way on the other side of COVID, I think what we learned here is that it's important to be able to offer these services on a remote way. You know, even if people can come in person, there's people that don't want to interact in person with the group, and to be able to offer options, just like I said, you know, offer a portfolio of group interventions, we should offer a variety of ways to interact with individuals. And then the last piece here on the challenges I learned along the way after doing this for 10, 12 years was that it really, really would have helped me if I had some startup technical assistance from communities or professionals that had been successful or had gone before me. I had to piecemeal this together. If I had had an organization or a group of people kind of serve as my mentors, here's how you fund this. Here's a way to sequence different programs. Here's a way to leverage your lay health workers or work with public health departments. It really would have got us to a scale much faster than it did. So next slide. So that brings up the next piece I want to tell you about over the next 3 minutes is the mission of the Evidence-Based Leadership Collaborative. And I would say that the EBLC is that type of organization now that I wish I would have had availability to work with 10 or plus years ago. We, as a board and as an organization, we're strategically developed to include people from community-based organizations like myself and people from the scientific academic development world like Kate Lorig, who developed many of these programs. Together, we serve on the board of this collaborative. And because we come from those sectors, we can challenge each other and we can work with each other to really come together at advancing the availability of evidence-based programs in diverse communities throughout the country. We have a unique way of working together. We have the ability to pull on each other's expertise when programs are being refined or when new programs are being vetted. Next slide, please. We come from a wide, diverse geographical area throughout the country. We have a number of individuals from California, University of Illinois, Maine Health, Washington School of Public Health, Sound Generations, the organization of Enhanced Fitness and Enhanced Wellness that Kate mentioned, Dallas, Texas, Cleveland, Ohio, Los Angeles, and Northern California. So together, this board, like I said, represents a number of different sectors, including developers and implementers. And the way we work is that most of our work to date has been in partnership with the Administration on Community Living and the National Council on Aging. And our group provides technical assistance for new programs that are trying to go through the vetting process to become an evidence-based program. But we've also had communities seek us out for technical assistance related to how do we implement a whole cadre of evidence-based programs in the Central Plains or in a part of the country that just hasn't been able to really get an uptake in these types of programs. And working with our staff and our board members, we can help organizations figure out how to do that in a thoughtful, strategic way that hopefully will be sustained. So we'd love to talk to you more about the collaborative. If you're interested, you can reach out to Kate or myself directly, and maybe there's ways we can work with you or your agencies, or we can just give you some insights that we've learned along the way. So I thank you for your time. And Jordan, I'm not sure, do we wait for questions or we're going to do those in the chat as we go?
You can type your questions in the chat and we'll do a large Q&A at the end, but definitely start to think about them. That's great. Thanks, Paul.
Great. Thank you, everybody.
Thank you, Paul. Thank you, Kate. It was really great to hear your presentations. And my name is Teresa Ambrose, and I work for the Minnesota Department of Health. I'm here today in Minnesota, where it was about 60 degrees a week ago, and we're expecting about 8 inches of snow today. So I'm really happy to be here. And in listening to the prior two presentations, I think the role that the state plays in increasing access to these evidence-based programs is as a middleman. We really are a connector. So I am going to share our journey with you, and hopefully it will help you get a sense of our role, and if that's similar to your work, it might give you some ideas of what you can do when you're launching these programs. So Minnesota received a state public health approaches to address arthritis grant in 2018. To get started, we wanted to reflect on what had happened at the state about 5 years prior to that, and when we did have a grant, by talking to our partners that were involved. Several staff had changed at the state, and we wanted to see what challenges, what successes, what needs, and what interest those past partners had, and to learn from their experiences. So we conducted key informant interviews with partners who had been involved in that grant, and that was used to kind of help inform our direction. So it helped us get up to speed. And we also did a scan of what programs were available currently in the state, which was really helpful to know who was delivering which programs. We loosely applied the RE-AIM framework to guide planning. That framework takes into consideration reach, efficacy, adoption, implementation, and maintenance. Our goals were to launch programs and reach large numbers of people, as was kind of requested by the grant, and to address health disparities. And sometimes that's a challenge when you're trying to reach, especially in our state, where it's 87, it's very largely white, but both were important to us. Because the effectiveness is proven for these programs, we don't have to do the extra work to prove that they're effective. We can really focus on making sure they're successfully implemented. We decided to focus on the Twin Cities metro area to have high reach. And we had some maps that were developed, which identified naturally occurring retirement communities where people were aging and were more likely to be experiencing arthritis. We overlaid this with maps of socioeconomic status to help target our communities geographically, and we also looked at other demographics such as race and ethnicity. We looked at that menu of options of all the programs that were evidence-based and identified by the CDC that were arthritis-appropriate. And after hearing what other folks were doing, where things were at in Minnesota, we decided to focus on Walk with Ease because adoption was good and it was only being offered at one point in the state at that point in time. We also wanted to make sure that as we launched or tried to expand access to this program, that it aligned with the goals of our partners and it also was sustainable. So when we thought about how we wanted to approach this, we wanted to think through who those partners might be that actually have systems in place. So our goals really were about increasing physical activity by increasing the availability, access, and awareness to the Walk with Ease program. In addition, we had some partners who were interested in chronic disease self-management program. It was also a really valuable program for other work we are doing on diabetes and cardiovascular disease. So those were our two focus areas as we got started. Kate mentioned a little bit about Walk with Ease. It's an evidence-based 6-week walking program. So the focus is on walking, although it does have other information about stretching and strength training. And it's for anyone who would like to start, maintain, or continue a low impact exercise program, which is really appropriate for those with arthritis or for those who have been really inactive or are struggling with pain. This helps people change their behaviors. It can increase balance and strength and walking pace. It can be delivered in a group. It can be delivered as a self-directed enhanced program where a coach may get together personally with a group once a week and then stay in contact during the week, send out emails, etc., or do this via Zoom or other platform. And it's also available completely self-directed, where you can get the book and follow along with the worksheets in the book, or also sign up on a portal and get the book and get some reinforcing emails. So recognizing the challenges of sustaining programs when grant funding goes away, we identified sectors and organizations with the capacity to provide ongoing programming. So Park and Rec departments, AAAs, healthcare, YMCAs, the University of Minnesota Extension, all of these organizations provide group-based education related to health and physical activity as a core part of their work. And they all have skilled instructors. The pandemic slowed down our work with Park and Rec departments, as many closed or stopped their regular activities over the past year. And YMCAs were particularly hard hit during the course of the pandemic here in Minnesota. But we have plans to move that work forward in the upcoming spring. Everybody's excited about that. And we are working closely with our AAAs, and we share master trainers or work collaboratively with them with training with those organizations. We had initially planned to partner with a large health system to integrate some of these evidence-based programs into their systems, such as chronic disease self-management or Walk with Ease. But due to a merger, as things happen, leadership changed at that organization, and we were not able to follow through with that partnership. So we've been focusing on some smaller clinics, some FQHC or federally qualified healthcare clinics. But we also want to have greater systems reach. So we're integrating these programs into other clinic systems work we're doing. We're trying to break down some silos, and we're working with our Wise Women program. And they are putting Walk with Ease on their list of evidence-based programs to promote. We're working with our healthcare homes and their efforts to educate about arthritis and let them know about some of these evidence-based programs. And we're working with our diabetes and cardiovascular programs to integrate some of these programs into their referral processes in the clinics. And the University of Minnesota does a great job of reaching underserved or low-income populations with lifestyle programs. They have great experience. They've been great partners for us in our state. So these were really key partners for us to reach our goals of sustainability, high reach, and impact. We also work with other sectors and partners to promote or deliver these programs. For example, in work sites, our state employee group health insurance program has been focusing on mental well-being, and physical activity can be helpful for mental well-being. So a walking program really aligned with their goals. So they were well positioned to help us promote this program to our state employees with a good high reach. We also have a statewide health improvement partnership in Minnesota, which is funded through the state legislature. We're really fortunate to have that funding to focus on policies, systems, and environment to support healthy lifestyles. That funding doesn't focus specifically on program delivery, and so our grant really helps supplement that work. So they work with 87 local public health agencies and 11 tribal groups, and they have a menu of options for their local public health partners and tribal partners to consider evidence-based approaches to improve health through lifestyle. And we were able to integrate these evidence-based programs into their work site and their healthcare sections of work. For our local public health, we also have, in our grant, we're really also focusing on increasing physical activity and supporting existing and sustained walking programs in the community. In Minnesota, we have a couple really great walking programs that were developed by our local public health departments and have been sustained for over a decade. And these are challenges or engagement opportunities where people walk for several weeks and track their steps and have peer support, get together. They reach a lot of people. And last year, Hennepin County Step To It program promoted Walk with Ease and made arthritis their focus for that year. And they also have a really broad network of park and rec departments, and work sites. And so we will be reaching out to those sectors now that people will be able to be out and about and getting together again soon. But people can do these programs independently as well. So the pandemic did not stop that effort. As I mentioned before, our Wise Woman program did recently add Walk with Ease and get it approved through their CDC grant to be included on their menu of options. And finally, because addressing health disparities is a priority for us, we are partnering with smaller community-based organizations that serve these communities. We also recognize that sometimes it's more challenging for those groups to sustain these programs. So here's a question. So this is a poll question, and please answer, which sector have you found most likely to sustain programs serving high-risk groups? So where are you finding that success and sustainability for these types of programs that we're talking about? I didn't put the AAAs down because they are definitely leading the way in these programs. Well, it looks like healthcare is the winner, that people are seeing more success with sustainability through the healthcare sector, which is great news because we definitely want to connect these community-based programs to our clinic systems. Often they integrate them within their own system. So that is sometimes a challenge to get them to refer outside of their system. I have to figure out how to. Oh, sorry, you can't see that. I'm sorry about that. So as you can see, healthcare got the most votes. So it's really important to recognize the value we can bring. I alluded to this as Paul was talking. He was talking about their role as a delivery system. And as Kate was talking, she was talking about their role as really developing these programs and making sure that all of the resources and tools to implement them are in place. And what do we do as state agencies if that's your role? Or how can state agencies help you if that's not your role? Well, mission alignment is certainly something we want to think about, when we're working with partners from our perspective, and we want to understand the goals they're trying to address and help bring solutions to them. We often forget that money is not necessarily what our partners need. Sometimes it is, but it's not always. So it's important for us to kind of listen to understand what our partners need and work with them to find those win-wins across different partnerships that we're connecting. So some of the things that are valuable to our partners from their perspective, and what we hear is our ability to bring people together, to convene stakeholders, using our existing networks, and our experience addressing health disparities. Health equity is on the top of a lot of lists for health systems, and they value our experience in that area. And health departments can increase credibility to gain the trust of healthcare providers. This can help facilitate referrals. So for some of our community-based organizations that are delivering programs and with lay leaders, et cetera, building that trust and credibility is important. In addition, we can help by providing data or analyzing data. Some of our partners don't have that capacity, but are interested in having more information. We can also support program promotion via our existing dissemination channels or through our partner channels who can also disseminate and promote. And we can integrate systems across our various grants, kind of break down those silos. We can make our other coaches and providers aware of these other programs to support cross referrals between these programs. And we can also provide training to new leaders. We have trainers on our team, and we can provide technical assistance, as Paul alluded to the need for some community-based organizations. And of course, we can provide funding when needed and when available. So I mentioned before that we really want to reach our diverse communities, our underserved communities, racial, ethnic groups. And we aimed to do this through some small partner grants to get them started. And so some startup costs, some extra support, bringing people together for peer sharing and peer learning are different ways that we do that. And we also recognize that some may need system support as well. So if they need that, we want to connect them to other partners who can really help them with that. So really our role is largely connecting our partners, connecting people to programs, connecting networks. To help our partners as they implement the program, we developed a toolkit. It provides information about the business case. Kate did a really nice job talking about really why arthritis is important, and we need to figure out what messages are important for the partners we're working with. It provides messages, different tools to promote the program, some social media content, and some images. We went out and had a contractor go get pictures of some real people in Minnesota, some diverse folks walking for COVID, wearing masks, socially distanced, to get a variety of things so that when our different partners pick up these toolkits, they can adapt it to their individual community needs. So in an ideal world, there would be a one-stop shop for providers and people to find these programs. This has been an elusive goal, as many organizations offer a variety of programs. That list I shared earlier. They have their own registration systems, or they need to have their separate systems for data purposes. But when it comes to meeting the needs of diverse communities or these small community-based organizations, having a network to join can be really helpful. So we've partnered with the Juniper Network. This group of people really understand implementation of programs, and where our local partners can be really great and passionate and just wonderful leaders, they may not have the staff capacity or the administrative support they need to do all of the other business functions, like setting up registration systems or payment systems. So there's a lot of other work that comes with operationalizing these. So we've partnered with a management services organization, Innovations for Aging, Juniper. So I'll refer to them as Juniper going forward. They're affiliated with the Metro Area Agency on Aging. So they really have a solid network through the AAAs, and they have a lot of great leaders and systems to support community-based programs. We added Walk with Ease to their platform as part of our grant work. now our community-based organizations can use that platform. And in addition, they have a great network of leaders, and those leaders can be trained to add Walk with Ease to their offerings. So it's a great way to expand the menu of options. So here's a list of the evidence-based programs that they do deliver. And as you can see, it's quite extensive. So they're becoming a hub in Minnesota for evidence-based programs. And this is really appealing to healthcare providers and systems and state agencies as we aim to connect people to the right programs at the right times. This hub also can offer a one-stop shop for referrals from clinics. Juniper has made arrangements with several managed care organizations or delivery systems in Minnesota to get funding or to help keep these programs alive and to support those health plans and providers in delivering these programs. They are able to kind of weave this funding together so that the community-based providers can also sustain their programs and make ends meet. So it's a really nice combination, and it helps our providers find programs, and it helps people find programs as well. So to date, we've engaged about 27 community partners to deliver the Walk with Ease program. We're integrating it with our other programs across our state agency work and really breaking down those silos and working collectively with partners and continuing to strive to do that more. It's definitely a work in progress. We've integrated Walk with Ease into the Juniper platform, and we're reaching some priority populations. So we're excited about that. Clearly, there's still much work to be done. And there are still many other places you can find these programs in Minnesota. So there is not a true one-stop shop, but there's a few very good stops that we can make, and it's getting easier to find programs. So one success story I wanted to share is when COVID hit, right? We all wanted our programs to continue, and people, whether it was the leader or the participant, using Zoom isn't always the easiest thing to transition to, and it can be stressful for some people. But because we had been doing some work with our University of Minnesota Extension team in trying to figure out how to make the diabetes prevention program adapted to lower income populations in a way that worked for them, we were really well positioned because we'd learned some things. We'd learned some things about what to do if somebody couldn't afford the data and how to address some of those problems, and also some of the other things about onboarding people. So the U of M piloted 5 cohorts with low-income populations of the Walk with Ease program with weekly Zoom sessions. They did the ground zero or individual pre-sessions with everyone to get them up to speed on the technology, similar to what happens with chronic disease self-management. And they have integrated this into their system. So they did this pilot, it was very successful. The instructors loved delivering this program, and they will be delivering it in an ongoing way. And they have the funding through SNAP to do that. We don't need to continue to fund them to do that. So some promising practices they identified, the importance of preparing for technology and sitting down one-on-one to get people up to speed. They engage people in a variety of activities to keep it interesting. They're very creative. They made sure there's time for individual sharing. They encouraged people to share pictures of their walks. They really promoted participants to interact with one another, and they connected with participants outside of the class. Oh, I want to share a little quote here quickly. One of the individuals said that, quote, "The most important gift was the motivation I received. I'm 85 and have arthritis. COVID, scared stiff, stayed home, completely stopped everything except TV and reading. I needed motivation desperately. I joined the class, bingo, the book, Darlis, the other members, it lit the fire. I learned how stretching is so important before and after. I loved the journaling, my walking and exercising and competing with myself. I started slow and built up to 30 minutes. Darlis and Christina made it fun and very informative. I highly recommend this program. And I think Paul alluded to the fact that, what do we do about the social isolation we're experiencing, especially with our older populations during COVID? And I truly believe these programs are an answer to some of that. People really enjoyed connecting in these programs during COVID. So we are grateful for the many partnerships we've had in our journey on trying to expand access to these programs. And we look forward to continuing to try to make these very valuable programs more accessible across our state. So I'll stop there and shift back to Jordan.
Thank you so much, Teresa. And thank you again to Kate and Paul. We're ready to switch it over soon to our question and answer. So I'm going to share just some information here from you. As a reminder, if you've thought of some questions along the way, or if you've already submitted a question, we'll check that out as well. But you can type in the chat box, which is located on your screen, and then we'll go through the questions in the order that we receive them, or if they connect to another question with the time that we have remaining for the webinar. We included a good amount of time here just to make sure we could have a good amount of discussion. So we really appreciate that. So I'm going to share this screen here so that you can see everybody and see what questions we've received. So if any speaker is interested in the question, I'll post this out. And if there's one that directed to a certain person, I'll include that as well. But did you find that you have an increase in participation as you conduct programs virtually? And that sounds kind of connected to the content we've discussed today.
I can answer what we saw in our state. We lost some programs and we gained some programs. But what we really did see was that participation was easier for many people who couldn't participate before. And that was great, especially for our rural areas. And attendance, anecdotally, we've heard attendance was better. There were fewer no-shows. We haven't analyzed that data, but that's what we're hearing.
Jordan, you're muted.
I was just going to say, Kate, I see that you're muted as well, and so was I.
Yeah.
Kate, you put a great response in the chat.
Yeah, it looks like our attendance is better. Sorry. It looks like people that started the program attend more sessions. That is, we have more completers. A completer would be 4 out of 6 sessions with our program. It looks like we're reaching people that we didn't reach before. We are also not reaching people that we reached before. And those are the people that don't have computers, can't afford broadband, et cetera, et cetera. And so that's why we also develop phone and mail options. So I think it's still a mixed bag as far as the national statistics are concerned. In the past year, we know that we've reached well over 10,000 people. We've probably reached a lot more, but that's because at least for the first 8 or 9 months of the pandemic, many organizations just diverted all their staff to other activities. And that's still true with a lot of places. So I think that the answer is still out there somewhere, and I can't give you a really clear answer, but that's the best we can do at this point from a national perspective.
Thank you so much. The next question that we received, this could be for any speaker, but it might relate to Kate or Paul. Have you addressed evidence-based self-management programs globally? And then there's some follow-up questions just to learn more about what that might entail, who that might reach, and if you have, integrated that in more of a national or community way. So there's a few elements that maybe you would touch on, whatever speaks to the work that you do.
Oh,
It's definitely a Kate question.
okay. We're actually working in about 30 countries. And I know that question came from Rob Simmons, who happens to be in Colombia. So we continue to work with the Pan American Health Organization, which is the Western Hemisphere branch of the World Health Organization. And so we're working in a lot of countries. One of the things that has made this much easier, and it's not just for our programs, and I'm now talking about SMRC programs, but also for all the evidence-based programs, is that not only have we moved a lot of the programs to virtual, but we've moved a lot of our trainings to virtual, which means that we can now train leaders, we can train master trainers via Zoom or other platforms. And this has meant that we've been able to do combinations that you'd never even think about doing before, such as people from Israel and people from the Ukraine all at the same time. Or in our master trainings, we've had people from Ireland and people from England and people from Russia and a few odds, and certainly a lot of folks from Canada. So I think that there's some real opportunities there on a global, to spread programs globally. And I think there's also some opportunities to spread them across the country in different ways and different types of coalitions. I'm already seeing coalitions that are not what you would consider natural coalitions. A rural state with a very urban state that happens to be 1,000 miles away. Things of this sort. So I think we're going to see some really different alignments of way things are done. And we'll just have to see where this leads us.
All right, and the next question that we received, I'll read this from here from the chat that I received directly. In any speaker in your work, have you reached out to medical societies such as rheumatologist practices to help get referrals to their programs?
Maybe I should answer that one a little bit. At Stanford, I worked and actually still continue to work part-time in the division of immunology and rheumatology. So I know a bit about rheumatology practices. That probably is not going to work. We've tried it. We've been trying it now for 30 years. And the reason it's not going to be work is what a physician told me not too terribly long ago. And that is, this is not part of our dance. And by that, I mean, we don't have time for this. This is not part of our routine. When you do a medical visit, from the patient's point of view, it kind of seems like it's not terribly well organized or whatever. But in fact, it's very routinized. You do review of symptoms, review of new symptoms, et cetera, et cetera. To tell people about an evidence-based program or any program, the fastest we've ever been able to figure out how to do this is at about 3 minutes. 3 minutes is 12, 14% of time of a 20-minute visit. And folks just don't have the time to do this. If you can set up a way that it can be done through the appointment system or the electronic medical records, yes. And so the way to reach out to people is through the electronic medical records and the patient portals, but not to expect that individual physicians are going to talk about this. They love us, but they never talk about us. I can tell you that the physician that mentored me for many, many, many years loved the program, is a co-author of many publications, never referred a single person.
Thank you, Kate. And
Oh, actually, I think Teresa might be talking. I believe you're muted.
Oh, sorry. I agree completely, Kate. I started my career as a clinical nutritionist, and I had a program, and I didn't even refer to into my own program half the time. Those systems are so important if we're going to get referrals to these programs, and that's some of the work that we do with our clinic partners, is work on electronic health record type systems for referrals.
Yeah, I will tell you that if you use the electronic health records, and you target, and the notice is a nice notice. And if you have direct links to the programs, there's some things that you got to do. But you probably will get a third of the people that you send it to actually respond to the email or to the electronic health record notification.
Yeah, one of the things that happens with yourjuniper.org, that group, is it's a soft handoff, or a warm handoff, so that if there's a referral made, they actually get a phone call and they can get connected to other social services, which is really nice because it's really individualized, and more likely for people to actually sign up.
Yeah. I mean, I think that that's a wonderful system, but it's really expensive.
The next question that I received here for Paul specifically is if you would be interested in sharing any qualifications, if there's a process or cost, whatever it might be, to join the EBLC, since we touched on that here in our webinar. And if so, could the state and local health departments join, especially if they're here on our webinar?
I thought I was going to make it a day without forgetting to unmute myself, but I made it pretty far. Well, feel free to send me an email privately if you like, separately. We can provide some technical assistance for public health departments. If you have a particular interest, we could talk through what you're looking for. We'd love to help you out in any way possible. So I'll make sure I give you my email address, and we'd love to engage with you.
We have time for about 1 or 2 more questions. If anybody would like to submit here in the chat, or if a speaker, if there's something that you want to reiterate or share based on this organic discussion we've had, you're welcome to share that here.
I guess the one thing that I would share is that no matter where you are, and these are for the people that have not done much of this before and don't know quite how to do this, if you'll reach out to us, we can connect you with the people in your area, because these programs are now wide enough spread. And you may say, well, why haven't I ever heard of them? Well, because they're usually done through aging organizations. They're not very often they're not done kind of through the traditional health education routes. And so if you reach out to us, we'll be happy to connect you on this, even on this webinar. There's a lot of the experts around the country. And you might say, well, there's nobody in South Dakota. Well, that's not true. There's lots of folks in South Dakota. Well, I am absolutely sure there's nobody in Alaska. Yes, there is. Well, how about rural Alabama? Yeah, we can find rural Alabama. How about Columbia? Yeah, we can probably even find Columbia. So reach out, and we'll help connect you to folks that are local and understand kind of what you have to go through in your area.
Hey, Kate, this is Elaine Alt. Thanks to all the presenters today for really insightful and engaging presentations. I had a question because I think, you know, as many health educators are thinking about getting started in this area, and we certainly want to support them to do so. We heard about the importance of sustainability, and if we're not getting a grant like Teresa was able to from CDC, how do we connect with, do we start to connect with ACL or just in terms of reimbursement or financial assistance to get started?
ACL has, both ACL and CDC have yearly calls, a request for proposals. And you can get attached, you know, you can watch for those requests for proposals and get aligned with those. But I actually think more importantly, to reach out to us now, and we'll reach out to the people in your area that are already doing this stuff, because they may be very happy for you to be part of their proposal. It makes them stronger, it makes you stronger. And I think at this point, well, certainly a new organization can kind of go at this alone. I'm not saying you can't do that, but you'd probably be better served to go at it as a coalition with other people. And again, we can, when I say we, Paul can do it, I can do it, the EBLC can do it. And we're happy to help you do that. As far as reimbursement, none of these programs are currently reimbursable except under some very strange codes, and only for healthcare organizations, because reimbursement can only occur to an organization that actually receives reimbursement from Medicare and Medicaid. And so the only programs that can do this a little more easily are diabetes programs. We're working very hard as the EBLC to make a better reimbursement route. But again, we can talk to you individually about that.
Thank you.
Another question we received, and I think this will be our final question. Paul, you mentioned an organization that was north of where you were running successful programs that weren't evidence-based. Could you please mention the name of that again?
An organization north of,
Open Hand.
Project
Oh.
Open Hand.
yeah. That's where I'm at, yes.
Paul moved.
They said thank you.
Thank you.
All right, everybody. We appreciate all your questions, and we're so glad that we could include all of your thoughts and your questions and additional follow-up in this recording today. We're going to share the speaker emails. You can see that in the chat, since the speakers wanted to share that so that you can ask any other follow-up questions or, you know, learn more about the work they're doing. And so let me just share some final thoughts that we have here today before we close up. So thank you again for joining us, and I'll switch over to our speakers in just one second. But to learn more about some more resources on behalf of SOPHIE, there is an ebook available, and we're promoting this in case it can be referenced in your work, Underserved Populations, Advancing Health, Engaging and Developing, or Up Ahead Research Handbook. This is in support from the University of Texas Health San Antonio. Additionally, if you're interested in doing and watching more webinars with us, tomorrow we have the Art of Conversation and Active Listening Schools. This will be at 2 o'clock Eastern Time. You can learn more about this on sophie.org and visit our calendar for all of our events. And finally, thank you again to our 3 speakers today, Dr. Kate Lorig, Paul Heffer, and Teresa Ambrose. We're so grateful to have your content expertise on this webinar and to be able to partner with you in all of this great work. And at this point, this does close our webinar today. So thank you to everybody who has joined us and wants to learn more. You'll be receiving a follow-up email. And if you have any questions, you can contact info@sophie.org. Otherwise, this does end our presentation. Thank you all so much.